Well, welcome to episode 201. I'm David Covington, and this is the Crisis Jam, your 988 learning community, and we've got a debate today. This was an exciting dialogue between Dr. Renee Keat and Arrow Foster in Amsterdam at our Crisis Now 3 Summit just about 5 months ago now. And we're going to, they've both polished up their arguments, and we're going to go at it again for YouTube and for all of you who are joining us here today. So you can always catch up on not only our debates, but the ongoing presentations at talk.crisisnow.com. The registration for the Crisis Jam, it's usually pretty straightforward after you've gotten in the first time. But if you need any support, don't hesitate to outreach our team. Today is debate day. Last week, we had Bobby Tanner with CIT for Youth. And again, all the materials, all the PowerPoints, the trivia, the news items, all of that information is easily accessible through talk.crisisnow.com. Quite a story of the tragic murder of the CEO of United Health in New York City. The New York Times had this article on the public's reaction to that killing, exposes frustration with the health system, in particular, the health insurance industry. In some quarters, the New York Times article says the suspect in Brian Thompson's murder is being defended and even applauded by Americans who share his outrage. Dr. Brian Hepburn, bring you in for a moment. This tragic murder on the streets of New York with a suspect at large. I think we all knew there were frustrations, but a little bit surprised by the extent of the public backlash.
Yeah, David, I would agree that both points that you just made, that on the one hand, the public outrage, the strong opinions about the healthcare system, I think we knew were out there, but perhaps not to the extent that they came out over the past week. It points out that we need to take another look at the healthcare system. There's a lot of anger about the profit motives, and that medical decisions may be more impacted by financial considerations than medical considerations. And looking at, do we need more regulation when it comes to healthcare? And that some of that gets lost when we're looking at the fact that this was a murder, right? And an individual died. There were children involved. There's a family involved, the community involved. But the outrage is so. I think it surprised many of us that that outrage was louder than the condemnation of the killing. And I'm not sure if when individuals were interviewed, they softened. They said that, well, they didn't mean that the murder, that they could rationalize the murder. They just felt that there was a legitimate concern about what was going on with healthcare. So I do think we need to take a look at it and perhaps reintroduce the ideas of having to look at other systems and whether they may be better. Maybe this is an opportunity to look at that. But there seems to be, David, an extreme reaction and outrage here.
So, Brian, when they made that announcement, they discussed that Brian Thompson was about to make a presentation to stockholders. And I've known that we had at least $300 billion companies in Anthem, Aetna, and United. But I was a little stunned when they said that he was going to report $450 billion in revenue next year. Did that number strike even you, Brian, or did you know that it was that large?
No, I did not realize it was that large. And I think that that's what people are comparing. They look at health systems in other countries that in many ways perform better and are less costly. I think that's part of the outrage.
Yeah. United came out with a statement and sort of doubled down on the mission of the company to avert waste and fraud and unnecessary procedures. But Anthem did make a reversal. That this story had been inching up, Brian, of their plan to reverse, their plan to limit more strongly the use of anesthesia, the duration of anesthesia, but they landed up reversing course right in the middle of all this.
Yeah, and I think that for most people, when they looked at that, Anthem was considering doing that, it just seemed to be so extreme, so that if you have surgeries that take longer, you're not going to pay for the anesthesia that takes longer. It just went against common sense, and it's given the profits that were the result of the system. It's pretty hard to look at these type of changes as in a favorable way. So I think it was good they reversed it, but it sounds like Americans are really wanting more than that. They really want to take a look at how do we get a better system.
Right. Okay, so it's debate time here at the Crisis Jam. And this is an actual picture of Arrow and Dr. Kate being playful at our dinner in Amsterdam. But let's go back and just quickly reflect on the history of debates at the Crisis Jam. We started with Dr. John Draper and Dave Atkins from Listen on AI should be the future of crisis care. And we did a fun video of an actual robot, Amica, having a lifelike conversation with a 60 Minutes correspondent. I was more impressed with Amica than I was the 60 Minutes guy. He was a little rude. But nevertheless, the audience in Crisis Jam, they said, we don't know. In the Likert scale from definitely no to definitely yes, there were strident voices on either end, but most of you were in the middle. And Dave and John did push you in the direction of more yeses. You can see our yeses increased quite a bit, but still the most dominant answer was, wow, a lot to think about. Our next debate, mental health should come with a police car. We're really talking about the co-responder model versus more of a community-based model where Erica Chestnut Ramirez talked about two old friends coming up, no guns, no badges. This audience, as you might expect, was strongly started. The baseline of before the debate was, no, that's not what we want to do, with only 2% saying definitely yes. But Jen did move the audience a bit, and we had a few of you change your positions toward more openness to certain scenarios. And then Vic Armstrong and I took on this issue of we should substitute the word emergency for crisis services. Vic and I both believe that parity with the medical emergency response system is the way to go. And so we may need to do this, but for the purposes of having a dialogue, as we started, the answer was pretty much, I don't know. And the audience after the debate was in the position of, yeah, let's use the word crisis. We want people to be able to define what that crisis is versus all of these insurance-based criteria and gatekeeping and blocks to getting access to care. So that brings us to today's debate 4, our second series as we get into the next generation of debates. And we're going to have hopefully a slew of debates over the course of 2025 as we begin to tackle some of these issues. But debate 4 is peer support specialists should be part of behavioral health crisis care services. Definitely no, don't know, not sure, yes, and definitely yes. And I'm going to take a moment. You're going to hear those arguments. Brandon Wilcox in the chat is saying we already are. And yet there are areas of the country and states and peer groups who would argue that the role of peer specialist in a service where there might be interventions that are forced on an individual, especially in the context of involuntary care. You're talking about a 988 service that might be involved. And there are other arguments. So I'm going to leave that to our debaters. Really enjoyed the discussion that we had in Amsterdam, and I look forward to that discussion today. So I think we've got a good, rich. I'm going to take a snapshot of the results for our baseline before I hand it over to Ursula. If I can figure out how to do that. Dr. Ursula Whiteside, welcome to the Crisis Jam. I'm hoping you don't have an ice bucket for me today.
No, not today. Not today.
Welcome. But before we start the debate, Ursula, stand by, Ursula. We're going to do a trivia hot seat question real quick. As we lean into this theme, if you were in the pre-show and you saw the world-class debater talking about the history, the Lincoln-Douglas debates in 1858 on slavery and its expansion into U.S. territories were a key moment in American history. There have been many such public debates that were not only pivotal for their time, but also influenced broader societal, political, and intellectual developments. The quote-unquote great debate was held during the 1920s between Shapley and Curtis. What did they argue about? And we're going to put this out to the audience, Ursula. Jump in, Ursula, if you want to help the audience think this through a bit. All of these were famous debates that occurred in or around the 1920s. But which one was the great debate with Shapley and Curtis? The rising threat of fascism in Europe, teaching evolution in public schools, the scale of the universe, or the impact of racial inequality?
This is a tough one.
This is a tough one, isn't it, Ursula? So this is back before any of us were born. This is solidly in the range that Ursula can't make an age joke with me because it's the 1920s, Ursula.
Right. I might go with A.
We've got A is trying to get in first place, teaching evolution in public schools. We've got people across the board. The great debate was actually between Harlow Shapley and Heber Curtis. It was on April 26 in 1920 at the Smithsonian Institution. And they argued whether the Milky Way is the entire universe, or the emerging idea was that it was just one of many galaxies throughout a broader cosmos. So teaching evolution in public schools, clearly there was around the Scopes monkey trials. There were debates at Oxford that were very famous about the rising threat of fascism. That was more into the 1930s, and many such debates about the impact of racial inequality. But today, Ursula, my video's not working. I've been dropping the mic here. But it's we've got the peers in crisis care, critical partner, are incongruent roles. And I'll turn it over to you, Ursula. Thanks so much for moderating.
Absolutely. We are lucky today to have two debaters, Arrow Foster, who's VP of Peer in Crisis, the Peer in Crisis program at Recovery Innovations, and Dr. Renee Keat, who is a psychiatrist and working in the Netherlands. So we will spend about 5 minutes talking about why, yes, we should be doing this, should be including peers in crisis-based services. 5 minutes about why not, and then we'll be spending a little bit of time with your questions and their answers, about 5 minutes, and then we'll have their closing statements, about 1 to 2 minutes. So I turn this question over to you, Arrow, first, to hear your side of the pro for involving peer support specialists in crisis care.
Thank you so much, and thank you, Dr. Kidd. It's great to see you again. So I am going to review 3 things that I think really impact this subject matter. One is I'm going to look at the recovery principles that impact this subject at hand here. I'm also going to look at how peers can enhance the care on an interdisciplinary team. And finally, we're going to look at the overall continuum of care and what peer integration does for that. So the inclusion of peer support staff, that's individuals with lived experience of mental health and or substance use challenges, it's crucial for advancing these principles and practices, for enhancing that care. And when we say enhancing that care, we mean throughout the continuum of care. It not only fosters a compassionate and empathetic environment, but also integrates lived experience into clinical settings and bridges the gap between crisis intervention and ongoing support. So first, let's look at those recovery principles. One, choice. One that Sam has said it should always be there. The principles should apply not only to the individuals we serve, but also those who wish to serve in crisis care. So as David mentioned at the beginning, there's a lot of pushback from the system and from other peers saying we should not, whereas my stance is it's the choice of the peer. Providing opportunities for peers to be part of the team honors their choice and commitment to give back to the community. It also acknowledges their valuable roles in transforming the healthcare system. Empowerment and hope, two of the strongest principles there are. Peer service, that living proof that is not only possible to recover, but it is achievable. The stories provide hope and inspiration by sharing their journeys that can overcome the challenges. It's a powerful tool in the process and instills a sense of possibility and motivation that clinical interventions alone may not achieve. It also does so at the time that the person most likely in their life needs this intervention the most. That goes right into the unique experience and perspective. It can foster a deeper understanding and connection with the individual in crisis. It enhances the empathy and rapport, which are crucial elements, especially in de-escalating crises and providing compassionate care. When someone in crisis sees that their supporter truly understands their struggle, it creates an environment of trust and safety that is often lacking in traditional clinical settings. And then back to the recovery-oriented approach. It focuses on strengths and personal goals rather than just focusing on symptoms and diagnoses. It aligns with the shift back towards holistic and person-centered care in mental health practices. And by promoting these principles and practices, the peers then help those individuals envision a future beyond their current status. So let's look at how this enhances part of the interdisciplinary team. We're not talking about replacing clinical interventions. We're promoting the data-driven proof of the enhancements of clinical services with the addition of peer support input. One, it creates the team collaboration. On the interdisciplinary teams, peers offer the insights that complement clinical perspectives. They lead to more comprehensive and individualized care plans, ensuring that all aspects of an individual's experience are considered. This collaboration enhances the overall effectiveness, integrating the clinical expertise with the lived experience expertise. It also supports enhanced engagement. One of the significant challenges is engaging individuals immediately and effectively. People in crisis are more likely to open up and communicate with peer support staff because they perceive them as relatable and understanding. They also see a shift toward mutuality in this relationship rather than the inherent power structure of the clinical and guest situation. This engagement can lead to better outcomes. They feel heard, validated by someone who's walked a similar path. This relatability breaks down the barriers and fosters open communication. And also, research has shown that the involvement of peer support staff can lead to a reduction in the use of coercive interventions, such as seclusion, restraint, forced medication. Peers can and often do de-escalate situations through non-clinical supportive interactions, offering a calming presence and practical advice based on their experiences. This aligns with the modern mental health care shift towards more humane and person-centered approaches. So let's look at the importance of peers in the overall continuum of care. We've talked about times in crisis, in engagement, and in de-escalation, but what about aftercare? Peers can play that vital role in ensuring the continuity of care. Their involvement can help bridge the gap between crisis intervention and ongoing support, providing consistent and continuous care that seems seamless. This transition helps prevent relapse and ensures that individuals can receive the necessary support along the full continuum of their recovery journey. It also supports that community integration and social support. Peers can often facilitate connections between individuals in crisis and their community resources, fostering that community and integration and social support through a common language of someone who has been there. They can help individuals build supportive networks, access community services, engage in meaningful activities. So, to sum all that up, because that was a lot in just a little bit of time, the implementation of peers and peer services is not really an option, but I believe it's a necessity and should be made available at any time that the person requests it. It's pivotal in advancing the principles and practices, enhancing care, and maintaining that continuum of care so the recidivism rates are not as high, and that includes the aftercare. Peers' choice to serve, their unique perspectives and ability to foster hope, enhance engagement, reduce coercive interventions, and promote those practices while collaborating effectively within the teams make them indispensable in providing what's considered a compassionate, effective, and holistic crisis of care. It's time we recognize and embrace this transformative power of peer support. Thank you.
Thank you, VP Aaron. Now we will turn this over to Dr. Renee, who will argue the opposite.
Yeah, thank you very much, and good morning to all of you there in the USA. Happy to be with you, and well, thank you, Arrow, of course, for your strong arguments, and it makes clearer also where things go wrong. I think in the thinking about this important topic, because indeed I'm very much in support of peer support. Everyone in life needs peer support, but what we are talking about is not the need of peer support. What we're talking about is what is a good place for the professional peer experts. And then there are 3 reasons why crisis care is not a good environment for professional peer experts to work in. Because being a good crisis care professional, you also bring your peers, bring your family, your friends, your neighbors, bring them or invite them, be active there. But is it a good place? No, it's not, for 3 reasons. First, there's the problem of the role confusion. Second, there is the emotional impact of the work. And third, there's a safety issue. One by one, the role confusion. The importance of peer expertise is about mutuality, about being equal. This, in this case, of course, in a crisis care, this cannot always be the case. In fact, it is by definition probably maybe the most medical part of it. And of course, our professionals, the other professionals working there, should raise hope, have empathy. But it's not the right environment for peer experts to work in, because it is in conflict with the equality. And in crisis care, sometimes you simply have to take over. So it's not the right place. So instead of bringing the peer expert there, it's for important that you are inviting to bring their own peers into the crisis care. And the role confusion is not only there for the peer experts, because the confusion that I heard very strongly in Erwin's arguments is, oh, we need peer experts to work on a recovery-oriented way. Well, then teach all professionals to work in a recovery-oriented way. Because in this way, you keep saying the thing that, oh, recovery is the topic of the peer experts. It's not the exclusive topic of peer experts. It's a topic that concerns to all. And because of this role confusion, is one reason why it's not a good place. The second, the emotional impact. And let's face it, the emotional impact of working in a crisis care is very, very high. And so also for peer experts, working in that environment, and I know it also from my own experience, it can trigger your own past trauma, for example. And let's face it, of course, it's almost like the elephant in the room. When you talk about peer experts, and I work a lot with peer experts, you select people based upon a vulnerability. That is the case. And this vulnerability is there. So it's not very wise to organize this ongoing exposure to the most triggering environment, because the vulnerability is there. And already you see that sick rates among peer experts are higher, and I fully accept it. You know, I'm a psychiatrist, I work with peer experts, I've been a director working with peer experts, and I always have to accept, of course, that sick rates are higher because you have selected people based upon that vulnerability. But it does mean that it's not a very wise thing to expose them to the environment with the highest emotional impact. And then third, there's the safety issue. Because you talk about an environment in crisis care that can be unsafe. So to work in that environment, you need additional training to be, and also an expert in the safety issue, to be a full member of the team. You say, well, then you do that training, of course. But then I think there are many more important things on my wish list for peer experts than become an expert in safety issues of crisis care. Please let the peer experts have that role in supporting their in other environments. So in short, why is this not a good place for the professional peer experts? The role confusion, both of the peer experts and of the other professionals, the conviction that only with peer experts you can really work in a recovery-oriented way. Well, that means a very severe shortcoming of other professionals. So you should work on that and not bring them to the second argument into an environment with a very high emotional impact, because there is this increased vulnerability. That's what you have selected on. And then the third, the safety issue, you can say, well, that requires extra training, but I think there are many more important things on the wish list for training. So that, in short, is why I think that peer expertise is very important. Professional peer experts are a very important contribution. Crisis care is not the right place. Thank you.
Thank you, Dr. Renee. So I want to point out that Dr. Renee was asked to argue the opposite. This doesn't necessarily reflect all of his experience and feelings. And I think one of the questions the audience has, or that we are thinking about, is the vulnerability that we all have as healthcare providers, peer support workers, in working in high stress environments when people are suffering. And would you say that it takes special training for a peer provider and for a non-peer provider to work with somebody who is in the midst of crisis, and that might not be something you get in your usual training? I'll ask that to you first, VP Aaron.
So if I'm understanding correctly, does that mean that you're asking if training needs to be involved before people work in the crisis center, no matter what position? Is that correct?
Right, correct.
Yeah. I'm going to agree with you on that, and I'm a bit biased. I'm a trainer, so I have to put that out there first. But I think that when you're working in the human field, working with other individuals, that extra bit of training is an absolute necessity, because it is not just about controlling your emotions. It's not just about being able to function well in this type of environment, but it's about understanding what that environment really looks like. So let me give you an example. Not every peer, not every doctor, not every counselor is right for the crisis field. If a counselor comes up and says, I'm going to work in a crisis center, is there a background check on their trauma? Is there all of these things that have been noted as a possible hindrance to having peers in there? Is that done on everybody? Or is it just done on peers? Or is it just seen as a peer vulnerability? I say that we go back to that word choice, and that is, if someone wishes to choose in that, to work in that, then they should be prepared. There should also be instruments. People should know what they're getting into. I'm not a fan of hiring a peer because they're certified. I'm a fan of hiring a peer because they are the best for the position and the situation that they're in. The rest of the training can come after.
Thank you very much. So to you, Dr. Renee, I'll ask a bit of a different question. What do you say to the argument that those who are struggling with issues of suicidal thoughts and other intense forms of distress, what do you say to those that say they prefer to speak with a peer support specialist in those situations?
If they prefer to talk to a peer expert, it makes a difference that you have, for example, a good connection with the recovery college, that you can organize, say, oh, there's the recovery college, and arrange that you have a talk with them. That's something different of being part of that crisis team. That's really another position. So for the reason I said, I don't think it's a good place to work. But I think, good mental health care is convening care. So it's very important that you have in your network a good connection with the recovery colleges, for example, that you can make this connection there. And as I said before, I think we all have too much emphasis that the only type of peer expert is the professional peer experts. So do invite. Then be a convener also there, and be inviting to people to have their own network involved in that care.
And that comment was based on, the question was based on Sean Hedden's comment earlier today. I wanted to see, as we move now to final statements, I'll open that up to you first, Dr. Renee.
Okay, I can have the final words for. Well, thank you for this debate, and I really my key point is indeed that all the arguments, or in fact most of the arguments mentioned by Arrow, refers to shortcomings of the other professionals. Peer experts are professionals, but if you talk about, we need empathy. We need a professional who gives hope. Those are important characteristics. Those are important characteristics of all professionals, and I see that the key issue is, and I'm going to mention that again in this way, that we tend to outsource recovery, that we keep on thinking, oh, if we want to have recovery-oriented approach, we need peer experts. And if we keep doing that, then other professionals can go on working exactly the same way and think, oh, we need peer experts, otherwise we're never going to work recovery in a recovery-oriented way. And that's the confusion here for me.
Thank you. VP Arrow.
Yeah, and thank you, Dr. Renee, for all those comments, because there are definitely things that we need to discuss and keep debating and keep talking about. I'd like to address a couple of things. One is the emotional impact in the environment may trigger past trauma. If that is true, we can say that about anybody working in the environment, not just peers, because none of us have lived a life without some sort of trauma or some sort of emotional impact. So we really have to look at that. We also have to look at the mutuality. If someone walks in to see me in my counselor role, and I'm both a counselor and a peer support, and they see that counselor certificate, they immediately see power. And I am not going to have the same conversation as I am if I walk in and I present myself as a peer. That conversation is going to be much more open. It is going to be much more authentic to them and for them. And I think that's where the power comes. I saw it in the comments a lot about the story. It's that power that comes with that creates that mutuality. So with that being said, I stand by that we should have them and they should be a part of the system. I do agree with my esteemed colleague that it doesn't necessarily mean that it has to sit separately, but can be worked together. And we don't need to outsource recovery, but we do need to involve that piece of recovery in everything that we do.
Thank you, Arrow. Over to you, David.
Wow, terrific work. Ursula, Renee, Arrow, thank you so much for sharing. Let's now go to our roundtable for some quick reactions and reflections. And we'll start with Shelby Rowe, Suicide Prevention Resource Center Executive Director, dear friend, and an amazing pioneer in lived experience with her advisory council. Shelby, what do you think about this debate so far?
I think it was great. And I love that our field has come so far that even, having the debate, we needed, essentially a straw man, someone who actually agrees that lived experience is important and the role that peers can play. So it's just exciting to see how far our field has come. But one thing that I think both brought up that I made note of is that kind of vulnerability argument. And I
Yeah.
love, Arrow's point of, we don't ask the mental health professionals or other first responders what their past trauma was. Years ago I worked, with another national nonprofit, and we were looking at the role of individuals with lived experience as peer counselors. And someone had said, well, but they may be vulnerable and they may not be able to because of their past experience. And I love we have one of our one of our vice presidents responded with, each and every one of us is temporarily able. There is not a single one of us that is immune from a crisis coming and completely traumatizing and incapacitating us. And so eliminating those individuals who have a proven track record of enduring and surviving trauma really hurts the whole system. So I loved listening to the debate. I love the respected role that peers have in our current crisis system, because what better way for someone who is struggling to be able to see someone that says, I know what this is like. I have been through this. You can get through it. So great debate. Really just here cheering on Arrow. But what a good conversation. I'm glad that you all hosted this today.
Thank you so much, Shelby. Now let's go to Justin Volpe, Senior Peer Coordinator in Nashville. Justin, the work you and Amy have done in this space has been terrific. What are your thoughts?
Well, thanks for having me, David, and I appreciate the discussion, something that needs to be talked about more in the peer field. I can say that, peers and people with lived experience can play a vital role in these situations. I've been a peer specialist for 17 years now, and for 14 years, I worked in the criminal justice field, getting thousands of people out of incarceration. And in that experience, who better can advocate for somebody that's had that experience in that situation? I think the problem lies in the field and for advocates in peers being co-opted into positions where they're part of a team that doesn't hold the same shared values of what peer support is, and being told to do different jobs that aren't in line with what our values are. And I've experienced this power differential working in the court system. To talk a little bit about the vulnerability piece, that's a really pet peeve of mine, that people think that people with lived experience can't, man up to the job or take that kind of environments, no matter what that is, because in my experience, in the criminal justice system, have seen other staff go into crisis, attorneys, um, other social workers, and we're all vulnerable at that time. And it is powerful work and a privilege and an honor to be at somebody at their lowest point and to get them out of a dark place. And we don't need labels with that because we all have been at the table, whether you're a peer specialist or not, and we all bring something with our experience. Um, Peers are the glue that holds the ship together, but we need to address people with their previous traumas, experience current issues, and meet them where they're at. Peer intervention can keep people out of crisis in certain situations, and that's really where I see it at, is making those connections and talking to people and meeting them where they're at. And the most times I've experienced people that were in crisis were because of housing inequities, because they didn't have food, because of real social deterrence of health that would evolve into a greater problem. And with peer support on the front line and meeting people where they're at with a cup of coffee and a pastelito like we do here in Miami, you're going to have a real conversation with somebody and know what's going on in a few minutes. And that's where that lived experience is very valuable. So I really appreciate the debate. I think you both have valid points, and thank you for your time.
Thank you, Justin, so much. I asked Sarah Dietz to join us, but Sarah works in the prison system, so she said, I'll be in prison today and not able to join. But Sarah was the
You're telling me that I'm worth fighting for, even on the days that I don't think I am.
So Sarah was the lived experience closing keynote in Amsterdam. And I asked her, because let's think about this for a moment. If one of the arguments is peers should not be involved relative to some of the work that has to be done in that type of environment, then what about a peer in the prison system? You could make the same kind of argument that the work of a peer is antithetical to the work of prison. So I asked her for her view, and this is what she shared with Kristen last night. I feel that being a peer and a licensed clinician in the prison system allows me to make connections and provide support for inmates that others in this same role may not. While ethically and for safety reasons, I'm not able to self-disclose, I can utilize my experience with anxiety, depression, suicide, and substance use so that my interactions come from a place of understanding and support, not just clinical knowledge. I've seen this aid so many inmates, patients, as they feel heard and supported rather than judged and minimized. They understand that they are humans with feelings, the ability to grow, and the right to be whoever they want, moving forward with a positive and healthy place. Ultimately, I believe peers are the key to healing in any setting. They open the door to more clinical support. So before we go to our final poll, Renee, I'd like you to just share the way you're going to vote, because we asked you to take the position of the negative, but let folks know where you really are. In fact, after Amsterdam, you came up to me afterward and you said, I didn't have the courage to push the fragility argument, and I'd do it if I had the chance to do it again. So today you pushed the fragility argument. I was watching Ursula to see how she would react to that. So Renee, let the audience know where your position on this topic, again, as Justin said, which has merit on both sides, but where do you personally stand?
Well, thank you for that opportunity, David. This may have been like the hardest 5 minutes in my life. First of all, I love debates because debate, although it's about opposition and wanting to win, it forces you to go in depth, also to the point of view of your opponent. So that's a very strong thing of a debate. So. And if I look then at my own arguments, the one that has the most passion maybe for me is this argument that I hear all these arguments in favor of a recovery-oriented approach, empathy, and therefore we need peer experts. And I really think that is a shortcoming argument because it is the belief that only with peer experts you can work in a recovery-oriented way. So this is really where my heart and my passion is. About the fragility, that's a complex thing because indeed I didn't want to mention it when we did the debate in Amsterdam because I think by itself it's a weak argument. On the other hand, if you go more in depth into it, there is the case, and I see many comments of that I understand in the chat. But of course, it is the case that we all have our vulnerability. I definitely have my vulnerability, and I'm open about that. But indeed, it is the case that you have selected peer experts on a sort of increased vulnerability. Therefore, I do think you must be careful in placing them in that environment, and that there's only maybe that many professional peer experts that you have. So this is not the right environment to place them. But for myself, I don't think it is a very strong argument in its own right. But also there is a tendency not to mention it away, to brush it away, whereas it is there, and I've seen that looking also at the peer expert in my own service, that the sick rates are higher than for other professionals, and that is something that is a complex thing. So therefore, there is even something to say for that fragility argument, but it does not come from my heart.
Thank you, Renee. So let's do a post-debate survey. Peer support specialists should be part of behavioral health crisis care services. We'll do that one more time and see where we get. There is some movement. Give that a moment. And I'm going to leave that open for a second so everybody has a chance to respond. Richard McKeon, Richard and I co-founded this Crisis Jam learning community together with a number of others of you 4 years ago, and these 200 episodes that we've had. Richard cannot join us today from SAMHSA. No one from SAMHSA was available. They're sprinting around the public comment. They're sprinting on a host of things, but the public comment around the service guidelines and the national guidelines for behavioral health coordinated crisis system of care. So you can use that URL in the QR code to get you to public comment, which I believe is open, through December 15th. And upcoming event, addressing behavioral health crisis in aging adults workshop. So Thursday, December 12th. And with that, let's go to Wendy Morris with NASBID for an update. Wendy, how are you feeling?
Right. Thank you very much, David. So good to be here, and what a fantastic debate. I am going to shift just a little bit, but maybe not as far as you might think, to talk a little bit about some myths that obstruct access to mental health treatment for people with co-occurring mental health and intellectual developmental disabilities, brain injury, or other cognitive disabilities. I know we're all trying to build crisis systems that are going to be as inclusive as possible. And just like when we talk about peer support, we want to be sure that we're not underestimating or making assumptions about the people that we serve. So can you go to the first slide, please? So just a couple very pervasive myths that we continue to encounter. First is that people who have IDD, brain injury, and other neurodevelopmental disabilities can't experience mental illness, and that is certainly false. Another pervasive myth is that these folks can't experience trauma because of their cognitive challenges. They don't understand what's happened. Also false. Third is that they can't benefit from evidence-based mental health treatments. False. And the last one I'm going to talk about is that their behavior is a symptom, if it's bad behavior, that it's a symptom of their disability and not mental illness or trauma, or maybe they're having a bad day like every other human. Next slide. So what are the truths? The truth is that a meta study has shown that there's a prevalence of 33% or higher of folks who have co-occurring or who have intellectual developmental disabilities, brain injury, so forth, have a co-occurring mental health challenge. So it's very prevalent, higher than the general population, in fact. Next. We also know that the rates of trauma for folks with these disabilities is also very high. They have higher rates of abuse, neglect, exploitation, including sexual abuse, social isolation, and bullying. They may have very extensive and invasive medical procedures and are not allowed to give consent. And for some, they're separated from their family. Next. Yeah, thank you. And in fact, we know that people who have intellectual developmental disabilities can benefit from mental health treatments. Now, sometimes they need some very simple accommodations, but there are ways to adapt many evidence-based practices for folks with disabilities. And lastly, we want to be sure that when we develop our crisis teams and crisis supports, that we don't just rely on behavior supports alone. They need to be used alongside other mental health interventions and treatments to assure that people are supported holistically. Next slide. I've talked, Mary Sowers from NASDS has been on here, the National Association of State Developmental Disabilities Director, to talk about the Link Center. Again, this is a project of national significance. It's funded by the Administration for Community Living and led by NASDS, but NASBID is one of the key partners. What you're going to find on this QR code or at this the link I have here on this website are resources, toolkits, sample forms, policies. It's going to include some of those adaptive strategies I talked about. You can find recorded shared learning groups on topics like trauma, crisis, transition, risky behaviors. You can register for our sessions in January on the justice system. I think I reported last time I was on, I talked about a 6-state policy academy that SAMHSA funded. where we had 6 states who brought together teams from mental health, IDD, 988, Medicaid, child welfare, others, to try to better build their crisis system. And then some really exciting work we're doing in the coming year is developing some videos based on SAMHSA's 6 principles of trauma specific to this population of folks with co-occurring disorders. We are engaging with emergency room physicians and nurses. We have gotten perspectives from people with lived experience, but we want to hear from the medical professionals about how can we do a better job of caring for folks who are in crisis that present to the emergency room. And lastly, we're diving very much into the kids space and hope to get some additional resources going there. So that's my update today. Thank you, David.
Wonderful. Terrific, Wendy. Again, a reminder, Texas, Ohio, West Virginia, and Pennsylvania are contemplating legislation that would drive 988 forward with those surcharges similar to the way we fund 911. We continue to have mobile crisis planning grants. And that brings us to Sarah and Joanna with AFSP and Guide Consulting for our federal update.
Thank you, David. We can go to the next slide. I'll give a quick update for the next Congress that will be starting in January, the 119th Congress, and some of the committees of jurisdiction that we deal with for a lot of these Medicare, Medicaid reimbursement rates, issues, policies, SAMHSA, as well as spending. So quickly going through, in the Ways and Means Committee, we will be maintaining the leadership of Rep. Smith, as well as Rep. Neal for the Democratic side, Smith on the Republican side. In Energy and Commerce, there is a shift in the leadership. A member that formerly led the committee is retiring. So now we've learned that the person taking over the reins will be Rep. Guthrie of Kentucky, and on the Democratic side, will maintain Rep. Pallone as the ranking member. We can go to the next slide. On the Senate side, since the majority has flipped, we will have Chair Cassidy on the Republican side for the Help Committee, and Ranking Member Sanders will move into that ranking member spot instead of his current chair role. On the Finance Committee, same members, familiar faces, Senator Crapo, as well as Senator Wyden on the Democratic side. Senator Crapo will be taking over the chair role. And then, move on to the appropriations. For the full committee, again, since they switched majorities, it will be Senator Collins as the chair and Senator Murray as ranking member. And on the House full committee, it will be Rep. Cole and Rep. DeLauro for the full committee. Got one more on the next slide. The specific subcommittees that have jurisdiction over health and human services spending will be led by Senator Capito from West Virginia, and on the Democratic side, it will be Senator Baldwin, and then on the House side, it'll maintain as Rep. Adderholt as chair, and the ranking member will be Rosa DeLauro on the Democratic side. I'm going to flip to Joanna quickly for end of year updates.
Yeah, so as we head into the 119th Congress, we still don't have an FY25 budget, but we are expecting, and I only just got this news actually like in the last hour, we are expecting a CR to drop this week. So hopefully end of this week, Sunday, Monday, we'll see a CR text that will keep the budget and the federal government running until March or April of next year. So hopefully we'll see that soon. Should have some good updates on what that includes. And thank you, Sarah. Yes, the CR is a continuing resolution. Sorry about that. We get lost in the lingo sometimes. So excited to hear about that. Also hearing that the Support Act could be reauthorized as well. And that includes some cybersecurity for 988. So we're keeping an eye on that. Hopefully we'll have some more specific updates. There's also an update from the FCC. They are seeking comments on geo-routing for text to 988. So I will drop that in the chat as well, because I know we're short on time, and I will pass it back. Thank you, everyone.
Thank you so much, Sarah and Joanna. And now to our ongoing segment on the Lived Experience Library. Since 1990 and the publishing of A Darkness Visible by William Styron, we've seen the field transformed by the voices of lived experience, and a number of authors who've shared their own recovery journeys. Eric Kramer, are you with us? Kristen, do we know if Eric has been? Eric, there you are.
Okay, that's what I thought. Hey, nice 88 or 988 t-shirt, by the way. It
Yeah, what do you think? And on the back, Eric, it says it's an Amy Brinkley quote, I believe, about the impact of caring. So, Eric, so great to see you again. It was wondrous to meet you and Eric Hipple when the two Detroit quarterbacks visited Phoenix, and we got to meet you. But tell us about the ultimate comeback and what inside you, Eric, made you write this book.
Well, I think at first it was kind of a long letter to my own sons in honor of Griffin, who passed away, but then Dylan also. And turns out I'm not the only one who suffered through depression. I'm one of probably a handful who've actually attempted it with a gunshot or with a gun and then not succeeded is a interesting way to put that. But thankfully I didn't. And so I'm here, and the book really is about my experiences in life, some overcoming immense obstacles to make it professionally, and then also dealing with some of the tragedies that also occurred in my life. But then also it gets into a little bit of my upbringing with my own parents. And so anyway, I think in the end, it's really about you know, what I've got with this second chance.
Yeah. Eric, what has been the public's reception to it, and what stories or letters that have come to you have inspired you or made you think you were glad you did it?
Well, everything I've heard back, and I wouldn't even know where to begin, but it's basically the gist of it is that from pretty much everybody I've heard from, they either have had a father like mine or a mother like mine, or in some way have suffered through depression themselves, or know somebody that has. And one of the things that I like to tell people is that don't wait until there is such a thing as anxiety or isolation or depression in your life. Be active, be proactive, in fact. And so begin at an early age, whether it's with kids or at an early stage yourself, and but construct and cultivate your own home team of support as you go along. That home team could include a therapist. And when you're a kid, it can include a parent, a coach, a teacher, someone slightly older than you, perhaps. And so that's the gist of it. Is once the sort of troubles mount and you begin to isolate, and the perspective that you would normally have, which is, the world is wide, it now begins to, you're looking through a keyhole, and oftentimes there's not really any light in there. So before any of that happens, be proactive.
Eric, thank you so much. This reminds me, Shelby was mentioning in her panel earlier about this shift from us versus them to all of us. And these stories make that shift. Eric, thank you so much for being here. We'll share the link and hope everyone will go on Amazon and get The Ultimate Comeback.
Very good. Appreciate the time. You guys enjoy.
Stephanie, give us a quick minute on a teaser for reading The Fallacy of the Stanford Prison Experiment in Crisis Talk.
All right. So some of you may know. Oh, sorry, it prompted me to start a video, but I'm not starting a video. So a new National Geographic documentary just came out. I don't know if you've seen it, but it's on Hulu and Disney. And it basically turns what people know about the Stanford Prison Experiment on its head. And it suggests that it's more myth than science. And I interviewed Clay Ramsey, who was prisoner 416 in the study. I don't know if you all remember this. I remember reading about the Stanford prison experiment, I think in my intro psych class. And just to remind you, it was 24 college students who Stanford professor Philip Zimbardo randomly assigned to be prisoners or guards. And the narrative, and I think this is where it's really important for the crisis sphere, is that it's really been used in defense of this concept of systems versus the individual in terms of culpability. And that was what Philip Zimbardo said was the outcome of the study. So check out the article, see what the documentary reveals and what Ramsey says. I also, just to throw this out there, added audio. So there's an automated, audio voice, and I'd love to get people's feedback. So I'll throw my email in the comment section. Let me know what you think.
Thank you so much, Stephanie. Rich stuff, and look forward to everyone reading the Crisis Talk interview. So our debate for today, this was a lot of fun. Thanks so much to Renee for visiting with us late from Amsterdam, to Arrow and Ursula for moderating. We started the baseline on this was, as you might imagine, look, there's some key arguments here, but peers are the magic sauce in all of this. And you saw that in our audience with 59% saying definitely yes. And that actually went up further, although we sprinkled some more no's and don't knows as a result of this rich dialogue. But overall, our definitely yes moved to 65. Look, help us think through debates for this coming year. I just got an affirmation from Dr. Margie Balfour that she wants to jump in for a debate on that crisis centers should take, or crisis receiving facilities should take on both voluntary and involuntary. We're going to have that debate early in 2025, so look forward to that. Next week, our last Crisis Jam of 2024, Dr. Brett Harris, SBIRT and suicide prevention and its potential for 988. We'll be off, as always, by tradition for both December 25th and January 1st due to the holidays. Thanks for joining the debate and Crisis Jam. And one more before we launch into a fresh start for 2025. We'll see you then.